everyone can listen to me. We are just starting our session for today. It's basically about the inborn errors of metabolism. I'm not sure whether how many people understand this topic, but this is a very relevant topic when related to the fetus or child having born with sepsis or any unknown disease, which the diagnosis is very difficult. So you just have to keep the diagnosis of inborn errors of metabolism, which is nowadays very common in our population too. Okay, so let's begin. When you talk about the inherited metabolic diseases, you just get an idea of metabolic pathways, I'm sure, because we are talking about the metabolism. So in metabolism, there are various metabolic pathways in our body, which is going on simultaneously, like carbohydrate metabolism, lipid metabolism, energy metabolism. These metabolic pathways are going. Dr. Shahid, can you please mute your mic?
Pardon?
आप लोग प्लीज अपना माइक म्यूट कर देंगे?
एक मिनट. माइक का कुछ जी मैडम.
आप प्लीज म्यूट कर दें अपना मॉडरेटर.
क्या करूं?
आप अपना माइक को म्यूट कर दें ताकि मैं प्रेजेंटेशन कर लूं.
ठीक है मैडम, आप स्टार्ट करें, मैं म्यूट कर रहा हूं.
प्लीज आप कर दें, मैं तो स्टार्ट कर चुकी हूँ. Students, can you hear me? I just only got Hadika's message. I hope we are having like 30 participants, okay, right now. Okay. Okay, thank you. Moderator, मुझे अभी भी शोर आ रहा है. Please kindly आप अपना mic mute कर देंगे, please. Okay, let's start. So we were just talking about the metabolic pathways, and these are simultaneously occurring in our body. And this is pathways, just to learn and to understand these pathways are very important if we are dealing with inherited metabolic disorders or inborn errors of metabolism, because inborn errors of metabolism are now also known as inherited metabolic disorders. Okay, this is very important. Now coming on to the introduction. What are these metabolic syndromes? Basically, these are what is happening. This is very, very, very important slide. We all must understand this. What is happening in these disorders or in these errors? There are the metabolic pathway which is happening, going on. Okay, there's one is the substrate which is converting into product. Any substrate that could be like tyrosine into phenylalanine. Okay, this is the substrate which is converting into the product. Okay, so whenever the conversion of substrate into product is facilitated by the enzymatic reactions. Okay, so enzymes are involved in these reactions. So whenever there's defect in the enzymes, basically the substrate will not be converted into the product. Okay, it could be any metabolic product, okay, or any metabolic chemical, or okay. So when the enzymes is not working, the substrate will not be converted into the product. Okay, so there is no enzyme, no product. So what happened? No product. Then there's start accumulation of the substrate. Now the accumulation of the substrate is a toxic metabolite. Okay, increase in substrate is a toxic metabolite which can lead to like bad effects on our organs. Okay, this is a simple definition of what is happening in the inborn errors of metabolism. Okay, I hope you understand that when substrate is not converted into product due to any enzymatic defect, okay, So substrate start increasing, accumulating. Okay, accumulation of the substrate then also lead to activation of different metabolic pathways, because that substrate had to convert itself somehow on the other. So it activates different pathways, which is not normal. Okay, and these alternative pathways can also lead to increased toxic metabolites. Okay, and these metabolites then leads to the clinical manifestation which happen in the inborn errors of metabolism. Now, these inborn errors of metabolism are the single gene defects. These are the genetic disorders. These are single gene defects, and these are congenital metabolic disorders that result from absence or abnormality of the enzyme and its cofactor, which is very important. Either the enzyme is deficient or the cofactor for that enzyme is deficient. Okay, which lead to deficiency or the accumulation of the specific metabolite, which I have told you in through this diagram. Okay, so mostly these feature as autosomal recessive trait. This is very important. It could come in your MCQs that these are the single gene and they transmit. Most of the disorders are transmitted as the autosomal recessive traits. Now the incidence, the collective incidence of inborn errors of metabolism are rare because they are also known as rare disease. And there's a specific day for these disorders in which the international community and we also there's a day like 28th Feb, which is a rare day disease. Okay, so these are rare diseases, but collectively they are common. Okay, and we here in Pakistan also seeing different data in which we have a high prevalence of inherited metabolic disorders. Okay, so mostly it's 1 in 1 lakh. Okay, births, but collectively it's 1 in 800 or 1 in 2,500 births. Okay, so collectively they are common, and like if you individually see, they are rare diseases. Now, how you classify? Basically, this classification is very rare, but you have to understand how we classify the inherited metabolic disorders or inborn errors of metabolism. There are 3 groups mainly broad when we broadly speaking. There's the group 1, which give rise to there are certain disorders in inherited metabolic disorders or inborn errors of metabolism that give rise to intoxication. Intoxication, how? Because due to accumulation of the substrate or metabolite, remember? So that accumulation leads to intoxication. Okay, so disorder that give rise to intoxication, which are aminoacidopathies, these are the disorders. Organic acidureas, urea cycle disorders, and carbohydrate disorders. These are the disorders which give rise to intoxication. Now, group 2 basically involves the energy metabolism. How? Basically, there are certain hypoglycemic disorders or certain fatty acid oxidation disorders which leads to the energy defect in energy metabolism. Last but not the least, the disorder involving the complex molecules like small molecules, and these disorders include lysosomal disorders and paroxysmal disorders. Basically, the small molecule means small organelles like lysosomes, paroxysmal. These are the small organelles which has very great impact. And whenever there is any disorder inside the metabolism of these cell organelles, so it gives rise to the inborn errors of metabolism. Now, why the diagnosis is challenging? It is very important because one thing is very clear that the diagnosis for inborn errors of metabolism is not straightforward. This is very important. And you must understand one thing: whenever a child is born, he or she is absolutely normal at the time of the birth. Okay, this is very important. If the boy or the girl is having inborn errors of metabolism at birth, but they are not manifesting yet, they are absolutely normal at birth. Okay, with normal Apgar score, with normal everything. Okay, but after 24 hours or after having feed, okay, they start manifesting those metabolic disorders. Okay, so the diagnosis is very challenging. It needs expertise, and the diagnostic expert diagnostic facilities are needed to to diagnose these disorders. Okay, so the episodic nature of these disorders and the wide range of clinical symptoms, like sometimes the patient or the child is only manifesting with sepsis, which is very common. You can first diagnose as an infection or sepsis, but the underlying cause is mostly inborn errors of metabolism. There's low incidence of these disorders, and there's lack of diagnostic facilities in Pakistan mainly. But nowadays, certain labs, I have also worked in that lab. Mostly my specialty is also in inborn errors of metabolism, and I have been diagnosing patients with inborn errors of metabolism. Okay, and I have also a paper from Pakistan which is now reflecting as a incidence of inherited metabolic disorders or inborn errors of metabolism in our population. Okay, which is quite common. Now, when we talk about the inborn errors of metabolism, the most common is the aminoacidopathies, that is related to the amino acids. Okay, so we have the phenylketonuria, PKU. PKU is very common. Okay, in Western world, it is also included in the newborn screening, because we in Pakistan are not doing inborn screening. That is, whenever the child is born, they take a heel prick blood from the heel side. Okay, and they just screen for various inborn errors of metabolism, like mostly 20 to 30 diseases in a single prick. Okay, so we are not doing here, so we have difficulties, obviously. So the most common inborn error of metabolism is the aminoacidopathies, that is phenylketonuria. Phenylketonuria is an amino acid. What is happening? Basically, phenylalanine is converted into tyrosine. That is what I was telling you, the substrates in the product. Now it's the live example. Now phenylalanine is normally converted into tyrosine. Okay, are you people with me? You just have to answer on the chat box. Just, I know that you are with me. Okay, thank you, thank you. So now, okay, thank you. Now phenylalanine is converted into tyrosine, thank you, normally. Okay, now what is happening if there's any inborn error in this pathway? Okay, because inborn error can happen in any one of the pathways. Okay, now this is in the pathway of phenylketonuria. The patient is having the phenylketonuria. What is happening basically in the metabolic pathway? The phenylalanine normally converted into tyrosine, but if the patient is having deficiency of phenylalanine hydroxylase, which is an enzyme that converts the phenylalanine into tyrosine, if there is defect in this enzyme in that child, the phenylalanine will not be converted into tyrosine. So what happens? There's increased accumulation of phenylalanine. Okay. Now, when there is increased accumulation of phenylalanine, which is coming from the dietary protein and the tissue protein, okay, this is toxic. And whenever this phenylalanine starts accumulating, it then increases its other metabolites, that is phenyl lactate and phenyl acetate. Okay. So phenyl lactate, phenyl acetate, phenylalanine, phenyl pyruvate is a toxic metabolite. Now this toxic metabolite then affects brain, lungs, kidneys, each and every part of the body of that child. Okay, so we have the wide range of symptoms, clinical symptoms. So this is simple. Whenever there is enzyme defect, and the secondly, there is any cofactor defect. Now what is cofactor? Now here, the cofactor for this enzyme, phenylalanine hydroxylase, is tetrahydrobiopterin. Okay, tetrahydrobiopterin is a coenzyme for this enzyme. Okay, now whenever it could be possible that phenylalanine hydroxylase is normal in this patient. Okay, but there could be defect in the mutation in the tetrahydrobiopterin. Okay, in the cofactor, coenzyme. Then also you can get the features of the phenylketonuria. Okay, are you understanding? Whenever there is any defect in the enzyme or the cofactor, you can get the picture of phenylalanine or phenylketonuria. Now, okay, PKU, basically there is mutation, okay, in the enzymes or the cofactors. Homozygous with autosomal recessive, homozygote means both the genes are for the this disorder, manifesting this disorder. So there will be severe hyperphenylalaninemia, okay, and this severe phenylketonuria, because both the genes are manifesting the disease. Now, 2% of the PKU is the phenylketonuria cases are caused by the coenzyme deficiency, that is tetrahydrobiopterin, BH4. Now, apart from the pH, that is hydroxylase deficiency, we can have the coenzyme deficiency, okay, which is very important for the pH activity or the hydroxylase activity, okay. So this is the pH system in which whenever there's any defect in the enzyme or the coenzyme, you can get the picture of the phenylketonuria. This is the inborn error, okay, which is very common in amino acids metabolism, okay. So how the patient will manifest if he or she is having the enzyme defect or cofactor defect? He or she will be normal at birth. I have told you, he or she will not exhibit any signs and symptoms at birth, okay. But after having the feed, okay, the infants start having increasing their plasma phenylalanine because the metabolism is started. So now there's gradually increased accumulation of the phenylalanine within the few weeks of the life, okay, and it will really affect the brain development, and there could be a mental retardation in the long run. Now, what individual may present with the seizures, fits, okay, there could be decreased pigmentation because the tyrosine is reduced. Tyrosine is responsible for melanin production, okay, so there will be decreased pigmentation and thus decreased melanin synthesis and eczema. This patient will also have eczema. Okay, the infant born to PKU mother, if the mother is having PKU gene, okay, and having high phenylalanine levels, the infants could have the microcephalic or mentally retarded. Okay, how you diagnose the this phenylketonuria? In Pakistan, we are diagnosing this disorder. Okay, it is through the amino acid chromatography. Okay, we run the sample in the chromatography. Okay, and we screen for elevated levels of various amino acids. So we get, if the patient is having the phenylketonuria, he or she will have the increased levels of phenylalanine metabolized in urine. Okay, this is the early diagnosis. And the only treatment for this disorder is the dietary restriction for amino acid, mainly phenylalanine. Okay, so the patient is restricted and will not be allowed to take the phenylalanine in diet. And because phenylalanine metabolites are toxic and it mainly affects the brain. The second disorder which we will discuss, or which is in our scope of this session, is the carbohydrate disorder, and this is the galactosemia. I'm sure you have heard this disorder, but what is galactosemia? Now there's a carbohydrate disorder which is going on, okay, and there's various sugars which is converted mainly into the simplest form, that is glucose, okay. So the intestinal mucosal lactase, okay, these are the enzymes which converts the lactose, that is when you take milk, the milk has the lactose, and that lactose is degraded into glucose and galactose, okay. So the intestinal lactase basically converts the lactose into glucose and galactose, and then further that galactose is metabolized to glucose by 3 additional enzymes. Those are basically galactokinase. See, this is the further metabolic pathway which metabolizes galactose to glucose, that is galactokinase helps in this pathway. Then galactose 1-phosphate uridyl transferase and UDP galactose 4 epimerase. Okay, these are the 3 enzymes which helps the galactose converted into simplest form, that is glucose, which is needed by various organs for energy production. Okay, so now what is happening in galactosemia? Now, whenever there is a galactosemia, there is the defect in the metabolic pathway, okay, conversion pathway. Okay, what is the most common conversion pathway which is detected, or what is the most common enzyme that is detected? Because we have that concept now that inborn errors of metabolism are due to enzyme deficiency or coenzyme deficiency. Okay, this is the ultimate thing which you people should know. Okay, so now when we talk about the galactosemia, now you have to see which enzyme is defective. Okay, now I have told you previously that there are three enzymes which is converting galactose into glucose. Now, in galactosemia, there is the most common enzyme is galactose 1-phosphate uridyl transferase, which is defected and it leads to the disorder that is galactosemia. Okay. Now, enzyme defect leads to abnormal accumulation of the metabolites. Okay, that is reducing sugars. And the most common enzyme which is defected and autosomal mutated is the galactose 1-phosphate uridyl transferase, GALT. Okay, which is also GALT. Other also affect the affected patient accumulates galactose 1-phosphate. What is happening now? You can understand this. What I'm just saying. I just read and then I will explain. Okay. So accumulate galactose 1-phosphate as well as elevated levels galactitol, okay, and galactonate. Okay, these are the toxic metabolites due to accumulation of galactose 1-phosphate. Now, what I'm telling you is this. Now, this is the pathway, metabolic pathway. What is happening? Galactose is converted into galactose 1-phosphate by the help of the galactokinase. Okay, this is the enzyme. Then galactose 1-phosphate is converted into galactose 1-phosphate, okay, glucose 1-phosphate by the help of this enzyme, which I'm galactose 1-phosphate uridyl transferase, GALT. Okay, and there's another enzyme, GALE, which is converting the UDP glucose to UDP galactose. Okay, so what is happening in the galactosemia? Number one, there's various types of galactosemia. Okay, so GALT is the most common, in which the galactose 1-phosphate is not converted into glucose 1-phosphate, and there's increased accumulation of galactose 1-phosphate, which is toxic metabolite, and then there's a back pressure or the backlog created, that is increase this, then increase galactose, and increase this galactose metabolites, that is galactonate and galactitol. Okay, so this increased accumulation of these metabolites lead to adverse effect on various organs. This is the process. When we talk about galactosemia, we have discussed that GALT is the most common enzyme which is deficient, but there are various types of galactosemia which you must just remember. It's not very important for you people, but you must remember that there's type 1, which is very common, that's GALT enzyme is deficient, but there's also type 2, which is due to glucosinase the enzyme deficiency, and GALE deficiency, which is type 3 galactosemia. Okay, this is the thing. But you must always remember that GALT enzyme is most commonly defective in galactosemia. Okay, how the patient will present with galactosemia? Now, whenever there is a mutation in the GALT, okay, the patient basically, this is very lethal disease. Okay, patient will present severely with failure to thrive in vomiting and diarrhea after the milk ingestion. Whenever the child is having milk, he or she will have the vomiting and diarrhea and failure to thrive. Okay, and the other pathological consequences could be there could be hepatomegaly, increase in liver size due to hepatic fat accumulation, cirrhosis of the liver. There could be cataract in the eyes, and there's non-specific CNS alteration, including mental retardation. Okay, these could be the clinical manifestation in galactosemia. How you will diagnose? Basically, you do the urinary screening test, which detects the reducing sugar. Okay, so the increase in galactose is the reducing sugar. So it detects the abnormal presence of the reducing sugar. Now, how will you treat the patient? Basically, you just due to that metabolic derangements in pathway, you just restrict the patient with having you restrict the patient for the dietary galactose for at least 2 years. Okay, you will not give the patient dietary galactose for at least 2 years of life. Okay, and if this disorder is left untreated or undiagnosed, then patient may exhibit the speech disorders or ectasia or gonadal failure. Okay, so this is all about 2 disorders we have discussed in inborn metabolism. That is phenylketonuria, which is related to the aminoacidopathies, and then carbohydrate disorders, which is related to the galactosemia. Okay, so these 2 disorders we have discussed, and the third one, which is the scope of our session, is the cystic fibrosis. I hope you people have understood each and everything up till now. You can answer me on the chat box. I will take the questions at the end. Are you people with me? Have you understand it? Okay. Now the third inborn error. Okay. Thank you. Now the third disorder which we will discuss under the umbrella of inborn errors of metabolism is the cystic fibrosis. Okay. Mucoviscidosis. Basically, why mucoviscidosis is basically this increased accumulation of the mucus. Okay. And this is fibrosis. This is a genetic disorder which is transmitted as autosomal recessive disorder. Okay. And now what is happening in this? They affect the epithelial cell ion transport. Okay. प्लीज अपना माइक म्यूट कर दें. आई गेस मॉडरेटर का माइक खुला हुआ है. मुझे थोड़ी डिस्टर्बेंस आ रही है. Okay. Now we will discuss the cystic fibrosis. What is happening in cystic fibrosis? This is basically the cystic fibrosis is a genetic disorder which is affecting the cell ion transport. Cell ion transport mainly of chloride. Okay, this is very important. Now we will discuss the cystic fibrosis in the context of transport. Okay, the chloride is transported within is an ion which is transported and it's in the maintenance of the homeostasis along with other ions. Okay, so whenever there is any defect in that transport in the epithelial transport of this ion, which leads to the abnormal fluid excretion in the exocrine glands. Okay, because that ion transport receptors are in exocrine gland, so there is abnormal fluid excretion or mucus secretion in the exocrine gland as well in the respiratory, gastrointestinal, and reproductive mucosa. So due to that cell ion transport defect, due to this mutation, there is abnormal accumulation of the secretion in the mucus, okay, in various organ or part of the body. You can see this is the healthy. When we talk about the lung, because it mostly affects the lungs. When we talk about the lungs, this is the airway with healthy mucus. Okay. Now, whenever the lungs is affected by the cystic fibrosis, the airway is having the densely packed with the mucus. You can see, and there's a the lumen of the bronchiole is reduced. Okay? Now, when we talk about the incidence, it's very common in Caucasians. Okay, it's 1 in 2005 live births. It's very common. But it's very lethal genetic. Okay, so the early diagnosis is very important. Now, when we talk about the cystic fibrosis gene, because it's a genetic disorder, basically what is happening? There's a mutation in the cystic fibrosis. Mutation in gene of the cystic fibrosis that encodes the cystic fibrosis transmembrane conductance regulator, that is CFTR protein. Now this is very important. You just have to memorize this. What is happening in cystic fibrosis? There is mutation in the gene of CFTR protein. Okay, CFTR protein mutation, gene mutation leads to the dysfunctional protein, that is CFTR protein. Okay. Now, what is CFTR protein is doing? Basically, it is helping. It's a chloride channel. It's a chloride receptor channel, CFTR, which helps in the regulation or the movement of the chloride inside and outside in the cell. Okay. So what is happening? How this what is the normal function of the CFTR? Basically, it activates the chloride channel, while the agonist induces the increasing cyclic AMP. Okay, followed by protein kinase A activation and CFTR phosphorylation. Whenever these three steps occurs, there is activation of these channels, which leads to the flow of chloride in the cell. Okay, or outside the cell. Okay, so there's two ways. Now, sometimes what happens, normally the CFTR is also associated with the sodium channels, that is ENAC, that is sodium channels, because the sodium is also an ion which is closely working with the chloride channel. So in most of the time when the CFTR is defected, the sodium channel is also affected. Okay, so there's in apical membrane, if you can see, normally we have the sodium channels and the chloride channels. Okay, there is a transport of chloride from outside inside the cell, and from inside of the cell to the outside of the cell, the chloride is going. Okay, in the airway lumen. So whenever there is a cystic fibrosis, what is happening? Now this CFTR basically augments the sodium channel activity. Now whenever there is no CFTR or defective CFTR, there's decrease in the activity of the sodium, and the sodium remain inside the cell. Okay, or there's increase in sodium inside the cell, and there's depletion of sodium outside and water. Obviously, when sodium is inside the cell, it also pulls water towards itself inside the cell, and there's depletion of the water and sodium in the outside in this mucus layer. Okay, normally it is a thin mucus layer normally, but whenever there is a defect in CFTR and there's a lack of sodium and water, this thick mucus, okay, in cystic fibrosis, along with depletion of the sodium, there is no chloride, sorry. So there is no chloride for the liquefaction of this mucus. So the mucus will be very thick and dense, okay, which is happening in the cystic fibrosis. Now, what is happening in the, sorry, this is the exocrine, okay? Okay, in what is happening in the epithelial sweat, basically this, whenever the chloride is affected by the CFTR defect in due to cystic fibrosis, the sweat is defected, okay, or because there is no flow of ions as it happens normally, so there will be defect. Okay, so what happens, basically there's loss of sodium function, there's hypertonic sweat. Okay, hypertonic sweat is this increase in chloride, there's no chloride and there's no sodium in the sweat, so there is a hypertonic sweat. So that is why you just do the sweat chloride test for diagnosis of cystic fibrosis. Okay, in respiratory and endothelial epithelium, normally CFT inhibits the sodium activity. Whenever it is defective, this sodium activity is highly affected. What is happening, basically the sodium is causing the increase in sodium inside the cell. Okay, whenever the sodium is not going out and remaining inside the cell, it is dehydrating the cell. We're basically dehydrating the upper luminal part or the mucus. Okay, dehydration due to whenever there's increased concentration of sodium, it also combines with the water because it attracts water. So the upper part of the mucus, which is normally thin, it's now very dense and dehydrated. Okay, and that dense and dehydrated mucus then lead to various clinical manifestation or hyperconcentrated viscous secretion. It leads to the obstruction due to ductal outflow. Okay, this is the lumen, basically sweat gland. Normally the chloride is getting inside and sodium is also normally they are functioning. when in cystic fibrosis, there is no chloride, CFTR is defective, so sodium is also remaining outside, okay, and the function is decreased, okay, so function is decreased. Now, this is for the sweat gland, but in airway, what is happening? This dehydrated mucus, because the sodium is getting inside the cell due to uncontrolled activity of this sodium channel, and along with the sodium, water is also getting inside. So this mucus is getting thicker and thicker, okay, in the airway. Now, when we talk about the mutational spectra or the genotype and phenotype correlation, the most common deletion or the mutation is happening for the in cystic fibrosis is happening in the phenylalanine at position 508, because there is a deletion in codes of phenylalanine at position 508 in the CFTR gene. So it is also known as delta F508 deletion. Okay, so delta 508 deletion leads to the defective intracellular CFTR processing, which degradation before it reaches the cell surfaces. So there's decreased activity of CFTR due to this delta F508 mutation. Okay, there's other mutation also, but the most common is the delta F508. This is very important. You people should remember that in cystic fibrosis, the deletion is delta F508. Okay, and there's defect of CFTR gene. Now, when you talk about the morphology, what is happening? Due to increased mucus or viscous secretions, what is happening? There's accumulation of the mucus in the small ducts and pancreas, okay, and there's total atrophy of the exocrine pancreas, okay, because due to accumulation of this, the function is the normal function is not happening, and there's atrophy of the exocrine pancreas. And along with this, there's a fat. They also affect the fat metabolism of various vitamins like vitamin A. So the lining of the duct of pancreas would change into ductal mucus metaplasia like this. See, this is the pancreas which is affected by the cystic fibrosis. There's total destruction or atrophy of the cell of pancreas and cell lining, okay, and there's replacement of the squamous metaplasia along with the normal cell lining, okay. So this is the mucus secretion, mucus accumulation within the duct. See this. Okay, well, in intestine, there's thick mucus plaque, because this is common, and you should understand the mucus is causing the defect in this disorder. So this thick mucus plaque, which is meconium ileus, and which causes the small bowel obstruction. In liver, also it is basically blocking the hepatic ducts. In salivary glands, mainly there's a glandular atrophy, and the lung, which is most commonly affected by this cystic fibrosis, has the mucus cell hyperplasia and viscous secretion that blocks the bronchioles. Okay, and when the bronchioles are blocked, they superimpose infections mostly by the Pseudomonas aeruginosa and Haemophilus influenza. Okay, this is the lung, which you can see the lung bronchiole is completely obstructed by the mucus, thick mucus. See this, and this is the intestine, which is having the thick mucus layer. Okay, intestinal, causing the intestinal obstruction. Okay, and in male genitalia tract, whenever the child is male, he or she can he can have the azoospermia with infertility, and in mostly 95% of the male, if they survive till the childhood, they can have the congenital absence of the vas deferens. Okay. Now, how they manifest? The patient with the cystic fibrosis manifests with whenever there's pancreatic exocrine insufficiency, they exhibit as malabsorption. Okay. The fat vitamins are not absorbed. There's a foul-smelling stools, abdominal distension would be there, and poor weight gain. Okay, and when the poor fat absorption results in fat-soluble vitamin deficiency, that is A, D, and K. Okay, so when there's A, D, and K, they can affect the vision, they can affect the clotting factors, and they can affect the bone mineralization. Okay, Then recurrent sinonasal polyps. Polyps can occur in this patient due to obstructions of the bronchioles. And then male or have the infertility due to obstructed agiosperm. Okay, so these are the clinical manifestations. Now complications, because due to these obstruction and these accumulation of the mucus, the cardiorespiratory complications are very common. That is recurrent infections, chronic cough, and obstructive pulmonary diseases are the basically complication for this disorder, and mainly they lead to death in approximately 80% of the patients. And the life expectancies for these patients are approaching 40 years. How you diagnose? Basically, you diagnose with biochemically, you diagnose with the abnormal sweat chloride test, because in sweat, you take the sweat, and in sweat, when you measure the chloride, there is no chloride, so you diagnose the patient as having cystic fibrosis. Or you can do the mutation analysis, and you can see the mutation in the CFTR genes. Okay, so this is the diagnosis for this disorder, and treatment basically focus on the symptomatic treatment, that is, for infection, you give them antibiotics, then you can replace the pancreatic enzymes, or you can have the bilateral lung transplantation. But these are very rare. Or recently, you have the potentiators. Potentiators are the oral bioavailable agents that basically restore the normal ion exchange or ion transport function, which is affected in cystic fibrosis. Okay, thank you. Now, any questions? I'm here to answer. We have 10 minutes. Students, I have finished my session. Any questions? I'm here to answer. Any suggestion? I know this topic is very rare, obviously, but this is very important, because somehow or the other, if you just go in your clinical practice, you will find this, or in peds mostly, but in totality, you will find these patients. And if you have interest, you can also have your career in these disorder, because it is a separate field to practice. Hello? Any questions? Yes or no? You can write. I'm waiting. Yes, because in CF patients, Minha, basically in cystic fibrosis, the patient is having this thick mucus secretion in all part of the organs, like in lungs, in pancreas, and heart, okay, and intestine. So because the ion transporting receptor is defective, okay, so it affects the all part of the body mainly, and mainly lungs. The most important for you to remember, the key points is this, that cystic fibrosis is a genetic disorder transmitted autosomally. It is causing the defect or mutation in the CFTR gene, okay, and it is due to deletion of the phenylalanine by the delta F508. This is very important. Patient manifests with increased mucus secretions in lungs, pancreas, intestine, okay, and these are only the main points which you must understand in cystic fibrosis. And diagnosis due to sweat chloride testing and mutation analysis. Okay, and treatment is basically You just treat the patient due to infections and all other conditions, cough and this, and then potentiators are the new treatment, which is the bioavailable agents that causes the restore the ion transport. Okay, these are the common points which you should remember. Okay, thank you so much. I think you don't have any question anymore. Thank you, Dr. Shahid, for moderating this session. You are on mute, Dr. Shahid. Okay, you can end the session, Dr. Shahid.